So today we're going to talk about dose response and how to impact outcomes, as well as some of the patient centricity, putting the patient first in what we do in terms of care. There we go, sorry. You guys all know this about completing your CEU, so we'll move on through. So our objectives today are to review the relationship between PAP and its clinical outcomes, to review suggested processes for therapy management, including patient-reported symptoms, as well as remote monitoring data. How are we using that? Because believe it or not, that really is patient-centric, and we're also going to talk about what is patient-centric care. And then we want to probe the benefits and patient engagement tools that are a new introduction into the field of managing really our patients. So first, let's talk about the relationship between PAP termination and all-cause mortality. Looking at new. So when we consider where patients are at, looked at 88. We looked at is continuation of PAP and how that there was there, as well as their incidences of heart. And those patients that continued on therapy as opposed to those who stopped therapy. We also know from a recently published journal that I think was like less than 2 months ago, we look at the impact for patients that admit into the hospital that are treated with PAP therapy when they have a congestive heart failure event and the all-cause outcome for them. So what I'm saying is we need to be very aware that PAP treats a number of things, and you guys all have heard me say this time and time and time and time again before. There are there are 8 billion untreated, it's an astronomical number, OSA patients. We haven't even started to touch the tip of the iceberg. So Byron talked earlier about HSTs, about how we need to embrace that concept. We've heard about how we can impact that therapy life for those patients with comorbidity. So what I'm saying is we've heard about Excite OSA that can be an adjunct therapy to what we're doing. We need to open our minds to be really looking at putting the patient in the center of what we do and providing the best clinical outcomes for them. And also looking to shift ourselves within our market. If we don't evolve, we don't continue to progress. Would everybody agree with that? So things change. We have to look at how are we approaching what we're doing from the future. Not just looking to get an AHI, but we know that there are other factors that impact. Like how many of you have heard of ODI and know how to calculate an ODI? How many of you are even reporting ODI on your PSGs? How many of you look at ODI on your HSTs? We're starting to find that ODI even has a better clinical indication than does AHI. So what I'm saying is stay current with what the literature is, where are we moving toward, as well as what are new testing options to get the best data for our patient, right? Does that make sense? And then, as we hear more about phenotyping and endotyping, how are we putting them in the right treatment pathway? Does that make sense? Okay. So the conclusion was when we continued PAP therapy for these patients during that first year of therapy initiation, it was associated with a significant reduction in mortality compared to patients that stopped therapy. So it is vitally important that we just don't meet a 90-day window. Let me ask in this room, how many of you really take on 90 days? How many of you do? A handful. How many of you, American Academy? How many of you know that the AASM is asking you to look at a patient disposition? How are you reporting that if you're not looking at it? Well, if you're not looking at it, you're not meeting that patient's needs, putting them in the center of what we do. So we want to make sure that we are really putting that patient at the center. You have tools that are very simple. How many of you associate your patients and look, how many of you are sleep labs first, or sleep centers? How many of you are DME? How many of you are physician office-based sleep patient management? Okay. How many of you associate or routinely review data in a cloud? Outcomes from patients. 1, 2, 3, 4, 5, 6, 7, 8. Those of you online, I would hope that you would think about this as well. 8, that's less than 10% of what's in here. Okay, does that make sense to you? So if we really want to put our patient first and look at changing outcomes for them, we need to start focusing on where those patients are in their continuum of care and engaging them in our care. So we know that negative effect of terminating PAP within that first year really does highlight the importance of staying on PAP long term. So not just a 90-day window to get paid. Does that make sense to everybody? As night sleep techs, does that matter to you? I mean, anybody, I got 2 in the front here. I know those 2 it matters to. It's vitally important for us to impact that patient outcome because that's why I love to do what I love to do. So looking at that, not only, how many of you in your hospital systems or your physicians, how many of you deal with an APO or an IPO or a insurance that you're at risk? How many of you know companies within your arena that are self-insured? Anybody? Do you know that with a self-insured provider, when they spend more dollars, what happens to the premium the next year? It goes up. Exactly, right? Even within your healthcare organization, if they don't make money, guess what happens to you? The trickle-down effect. You get no pay raise. You get no additional income, right? So let's put this in realistic dollars of how this impacts us. We know that when we treat patients with PAP, and this was a study that was done in 2019, and what they actually looked at is patient health management data. So what that means is how much did it cost me to treat this patient? We found, and they looked at patients, they looked at 1,098 patients that came in for care. And they evaluated those that were adherent and compliant to therapy using it at Medicare guidelines 4 hours a night, more than 70% of the nights, and they compared those to those who fell off care. And they looked at what their health care spend was. They found that those patients that used PAP on a regular basis had a reduction in inpatient admissions, a reduction in ER visits, and for every 1 hour of PAP that they used it beyond 4 hours, it had a 8% reduction in inpatient visits and a 4% decrease in overall access to patient care. Now, is that important? So if I'm going back to and you guys have heard me say this before, I know you have. If I'm going back to my healthcare institution and they're saying, well, we're not really going to give any dollars to this sleep lab because, we really can't see any impact. This is significant impact. If you're not seeing it on the top of the tireless tree and yelling out for them all to hear, shame on you. I truly am an advocate for those type things. We really need to help people understand how much this impacts what we're doing. So our conclusion is that continued use of PAP in the first year of therapy really is associated with a significant, that's the wrong outcome. Let's look at this bottom one. A patient, somehow, this went through label review, by the way, so we're going to make sure that we know that. A patient in a healthcare system evaluating methods to reduce medical costs and treating OSA should be considered the solution. So if your healthcare system is at risk, if they're contracting with IPOs and they're part of their own internal HMO, or they're participating with Medicare at a higher risk dollar scenario, they should really be considering what they're doing with OSA. Implementing internally some sort of screening process and making sure patients are being treated appropriately. Does that resonate and make sense with you guys? Okay. So this last study that we're looking at right now currently was done by Weaver, and this is a little bit of an older study, but what they looked at is the relationship of PAP and achieving normal levels of daytime sleepiness and daytime function. So when we think about putting the patient at center, we heard from Ray talking about how snore impacted bed partner and sleepiness, right? But what do you think impacts overall patient quality of life? When people come to see you, what do they complain about during the day? What do they feel? Tired, fatigued, sleepy, right? So look at using PAP and its impact on daily sleepiness. We know that the estimated dose response with the duration of use impacts that daytime sleepiness. 149 participants in the severe category, And of those patients, these were 7 sleep centers in the United States. And darn it. The results were that there was a linear dose-response relationship. So, meaning statistically significant, that's hard for my tongue to say, a p-value of greater than or less than 0.01%. So between that increased usage and achieving normal level for conclusion is that the greater percentage of patients will achieve normal function with using nightly PAP. And increasing their duration improves their overall outcome. So again, patient center, making sure that we're improving those factors that impact their quality of life. We know that PAP reduces snoring. We know that it improves their daytime sleepiness. So all of these studies kind of lead to putting that in the center. Management that puts the patient in the center of what we do. So I want to define for you, what does patient centricity mean? Patient centricity is defined when you are putting the patient first in an open and sustained engagement of the patient. You're respectful and compassionate in achieving the best experience and outcomes for not only that patient, but for their family. Okay? Being the patient first in sustained engagement, in a sustained, engaging environment, respectfully and compassionately achieving the best outcomes and experience for that patient. How can we do that? How can we within the sleep center really affect a change for these patients and putting them first? It starts with you, the clinician. It starts with really, first of all, seeing their physician. But making sure that we are all collectively having the same conversation, that we're really identifying where those patients' needs are, that we're not assuming that they know why they're there, right? How many times does a patient come into your lab at night or come to pick up a home sleep test or come to pick up their PAP device and they go, well, I don't really know why I'm here. Okay, that's not putting the patient first, right? We need to all be on the same page with the same education, understanding what the needs, what is the goal of that patient? Not only what's the goal of the patient, but what's the goal of their family, their bed partner, right? Because that's where we impact quality of life, and that's where we impact overall health. That's putting the patient in the center of our care. There are 4 C's to patient centricity that I want you all to put into your pocket and consider. The first C is first contact. What is that interaction with that patient via face-to-face, via telemedicine, via an email, via an online via teleconsultation? What does that process look like? Is it user-friendly? Is it cumbersome? Is it burdened? Are we putting the patient first? Are we making it easy for them to access? And when we communicate, is it clear? Is it concise? You know, we don't need a lot of wordy documents. We would be better off to put 4 bullet points to 6 bullet points that the patient's quickly going to be able to absorb. What's the education level of what we're presenting to our patients, right? Because the average person can only consume on a 4th grade level. If we're trying to convey information at higher than a 4th grade level, they're not going to be able to typically take it in. So how are we approaching them? Second C is comprehensiveness. What are we including? What is the scope of all of the options that are out there? Are we discussing with them that this is a lifetime pathway that they're on? And let me also clue you into this one result. It is an epidemic in our country at this current time with obese children. Did you know that a child at age 8 who is diagnosed with OSA, tonsils and adenoids removed, that child is a lifetime OSA user without weight loss? Recent study, 2021, looking purely at the endemic proportions of adolescent obesity. 8 years old, if they are still unresolved OSA at 8, they are a lifetime PAP user. Is it important how we approach them? Absolutely. How many of your labs are doing adolescents? How many of you are talking to your pediatric? Absolutely perfect, because that really, again, impacts what we're doing. And for looking at endotyping and phenotyping, we really have to look at that for our children moving forward. How are we managing them, and what options do we have out there for them? And I do believe that in the future we may see more conjunctive therapy, things that we're working and utilizing together. So, that comprehensiveness, the coordination of care. So social issues, linking the healthcare environment, the referral process, technology, leveraging that improved coordination and monitoring of our patient benefits. How are we using these tools? Do we know that our physicians have the access? Are our physicians using a telemonitoring piece? Do they have access to the data that they need to be able to appropriately manage their patient? And how are you in the lab engaging? You and the DME engaging? Are you communicating cross-functionally? Not just getting the sleep study and going, oh, well, that sleep lab didn't really know what they were doing. Look at this results again, man. I can't figure out what this patient needs to be on. Not that. It's communicating, saying, what can we do better? Does that make sense? And then last is continuity. Again, that relationship between management, information, practice level, patient-focused, and disease-focused. So if we understand that our physician's asking for a different mode of therapy, and we don't know why, and we don't have a grasp of it, sitting down and bringing everybody to the same table and saying, hey, let's understand where we're at, so that we know that we're moving forward in a patient-centric environment, that we're all on the same page, and I know what you desire for the outcome for your patient. Because if we don't, guess what? I was on the phone for 3 hours the other night with the sleep center, and they had no clue what they were supposed to be doing. They're asking me to troubleshoot their transcutaneous monitor and to tell them when they should put O2 in place. And I'm like, I'm not your manager. I don't have your policy. Have you talked to your doctor? You know, what did the note say? You know, I don't know. I can't find the note. Holy manure. And that's where we're going to leave it. So, I mean, just know if we're not coordinating care, we're missing opportunities, okay? So we've talked about the 4 C's, we've talked about patient centricity. I understand I might not have provided you some solutions, but hopefully by the end of this, you're going to see that there are potentially some solutions. So when we look at data we can see remotely, we know that there are when we use telemonitoring systems, that we help increase overall nightly usage for PAP, that we significantly improve adherence to those patients with moderate to severe OSA. Also know that in cases where patients experience persistence of respiratory events. So again, let me ask you one of the questions. I want you to think through this. How many of your patients come in now with complex comorbidities? How many of you move off PAP? How many nights do you move the person from standard plain CPAP to another mode of therapy? Every night? How many of you have very clear pathways and direction from your physicians and the ability to be able to do that and make clear decisions? Excellent, good, because that's what's vitally important, that we're making sure we're assessing. And again, to David's point earlier, there's what I consider to be 5 major, well, actually 6 vital signs when we add in tidal CO2. You should be documenting at every biometric check, every 30 minutes, and every time you make a change. Heart rate, respiratory rate, SpO2, leak, tidal volume, and in-tidal CO2, TCO2 if you have it. Why? How many of you document tidal volume on every breath? For every I suggest that you start doing that. Why? Because you're seeing complex patients in the lab. You're not seeing standard OSA in the lab anymore, rarely, right? Most of these people have complexities. The more data points you give your doctor, the more they can understand why you've done what you've done and what the standard level of care needs to be moving forward. Does that make sense? If we're not achieving appropriate tidal volumes, what's the problem with that patient? Is it obstructed airway events or is it ventilation? And could it be also perfusion and ventilation? Because, right, don't you have to have both for you to have oxygenation? And don't you have to have both to lower CO2? Excellent, good. So, I mean, that's what we're saying. We have to make sure that we're all communicating on the same pathway. Being able to know that we're looking all at the same information is going to help us more effectively communicate with our physicians and say, hey, this person just didn't look quite right. When we're in the lab, the doctor may say, well, we're going to start on PAP. But if you're looking at their PAP data and you say, boy, their respiratory rate on each night is still running 26, 28 on PAP. Their tidal volumes averaging like 380, and that's only 80% of their predicted. Man, you know, I felt like they needed to go on bi-level, but the doctor was conservative. I really should point this out to somebody. Does that make sense what we're saying? So just using that data. We also, and patients can be engaged in their own. How many of you on a nightly basis, or when you come in for, I know when you guys probably come in to set them up, everybody talks about engaging them in a patient engagement tool, right? MyAir, Dream Mapper, does everybody talk about that? Everybody bring it to the patient's forefront? Can I ask one person that would be willing to tell me what they talk to the patient when they say that? What's your talk track? Anybody willing to tell me what they say when they try to get a patient to make sure they're going to sign up for Dream Mapper or MyAir? Anybody? Yes, sir. It gets them involved and their outcomes are better. Good start. Really good start. I would encourage you to state that this helps them to also convey information to their physician, and that by getting engaged, they know where they are, they understand about resupply, they have tools that, like, how many times, when does a patient usually struggle with their PAP? When they first put it on in the middle of the night, right? So that's 11 o'clock at night. How many DMEs have somebody on call to say, here's how you put your mask back on, Mr. Smith? Your DME, they'll call you at 11 o'clock at night and you tell them how to put their mask on? Well, and I'm going to ask you how many patients call you at 11 o'clock at night and ask you how to put your mask on.
We have a team of therapists and nurses that answer those calls.
Right. So you don't know how many?
We have
Yeah. I can tell you that most patients don't. They're like me. And like me, I put it on, I would say a few backwards and throw it to the side and say, I'll call somebody tomorrow for help. And then what happens is I look at my watch and it's 4:59 and I call and it's like, they've rolled the service over. So 3 days goes by and I remember again, and the next thing I know, it's 2 weeks to 3 weeks down the road and I'm already giving up on what I was going for. Right?
One of the things I always tell every patient is, you take this home and play with it a little bit.
Sure. How many do?
I have a fair number that do, not all.
Yeah. And that's the problem, is that they get ready for bed and they put it on and then they're overwhelmed and they don't know what to do. But when you use a patient engagement tool, guess what? They have at hand somebody that's going to teach them how to put their mask on. Here's a video. Put your mask on. Reminds me how to do it. I forgot how to add water. Here's a video. Here's how to add water. Engaging your patient, having education for them right at that point at hand. So we know when we look, this is a retrospective study that was done looking at patients, 128,000 patients that use a patient engagement tool. And what they found that those that were actively using engagement, 87.3% of those patients met CMS guidelines when they were actively using, and they increased their sleep to 5.9 hours per night, which is a 1 hour increase in how much they used it, and they increased in their overall adherence and usage, meeting Medicare guidelines versus the usual care group. So engaging them in their care gets them improvement in their overall. So adopting those advances in technology, getting them and encouraging them, and to your point, this is going to help you be better, but this is going to give you long-term improvement in your sleep, in your health, and your overall well-being, because sleep deficit impacts you this way, and this way. Helping them understand that this is not an option, that they really should not be opting out, but opting in, right? Because I know everybody talks to them about it, but what do you think the average patient is that engages in this app? US-wide. 30? Anybody got a number? Bid. Anybody got a number? See, it should have been an auctioneer. It's around 60 to 64% of patients long term. So well, as low as 30, as much as 60. You know, engaging people is really going to make a difference in that impact and that overall. Nope. Actually, what we find the people that engage the most are older, at least in our studies. It's the older patient group. It's the older, the younger, it's the 30 to 50s that don't, because life's too fast. Yeah. It's the older group, the older and the younger that do. So asking you a question, do you think you can predict compliance? Can you predict a patient that's going to be adherent and compliant? This is a study that looks at the strongest predictor of long-term compliance is the initial use of CPAP. So we know that after the first 4 days, we can pretty much predict whether they're going to be adherent at 2 months. And evidence indicates that as early as 2 weeks after PAP is initiated, we're going to know if they're going to be a long-term 1-year user. Right? So those first 4 days are important. How many of you are seeing patients or looking at data at the first 4 days from when you set them up and reaching out? We don't have the bandwidth usually. But guess what? Glancing and taking that time and saying, putting your patient that needs you at the forefront as opposed to managing everybody, look at those that are struggling, the telemonitoring apps that really will put those patients in groups to let you know if you're looking at their hamburgers or if you're setting alerts for them, depending upon whose software that you're using for patient management, you can predict or see who's failing. So where you spend your time is more appropriately engaged with the patient that's struggling as opposed to managing everybody. Because typically who we manage is the one who calls us. And who calls us? Sally Jane, who wants to chit-chat, right? So we need to really be looking at the patients that need us, not the patients who want us. Does that make sense what I'm saying? And don't really need us. We need to engage the people that really need us. We also know that the use during the first 3 months is the best predictor of long-term adherence and compliance. So really getting them adherent early and then continuing to focus on them is going to help us not to fall off. So if I'm monitoring them and I'm looking at data, of these data points, I have a number of data points up here. Just by show of hands, how many of you think utilization is number one? You pick multiple, by the way. How many think utilization? How many do, when you're looking at it, what do you look at? Utilization. Oh, nobody. Yeehaw. Leak. AHI. Tidal volume. Anybody? Any takers on that one? Respiratory rate. Percent trigger and cycle, as well as their IE ratio. Dave talked about these earlier today. What about patient enrollment and their engagement app? And then we're going to talk about some new things here called Care Check-In, a new way to engage your patients. Of those, do you think any of those are ones that are important that you're looking at? If you're only looking at your patients in the first 4 days to 2 weeks, if you're the sleep center, I mean, you come in at night. Most of you guys come in early, a few minutes early, right? You got a few minutes to get your stuff together. What about if you just pulled up your screen and said, because you're going to know who was set up, because the most recent is going to go on the top of whoever came out of your lab that you're associated with, and you're going to be able to say, oh man, we need to leave a note for somebody to follow up with Sally Jane because she's just doing crappy. I was afraid of this, right? Is that getting that patient-centric measure? That we're coordinating care and that complexity? So looking at all this data is really going to give us input. And how do we use this information? Using the information such as leak, because again, to Dave's point earlier, leak is the one of the number one reasons that people struggle, right? And it's the hardest thing to control for a certain patient population. And if we have leak and we're on an auto device, like APAP or ASV or a volume assured pressure support mode, something that's not fixed pressure, does a leak impact how that auto algorithm responds? Absolutely, because if it can't determine what event type it is, what does it do? Doesn't move, doesn't change pressure. Could it under or overestimate how much volume they're breathing in and out with every air? Absolutely, because when it exceeds what we consider to be the intentional leak, and it goes above that 24 liters, it starts counting it into patient volume. And when it counts it into patient volume, then the algorithm may never respond to increased pressure support that they may need. Does that make sense? Okay, so that's vitally important for our patients. And again, when we look at our, whoops, boy, that's a really cruddy picture. Sorry about that. It didn't come through very clear here, did it? So when you're looking at your reports, let's look right here. Percent cycled and triggered, that's for those patients that may be more complex. If they're not cycling their breath, that means that they may be breath stacking, right, as we learned earlier today. If they're not triggering, they're not getting that breath in. And then when we look at their respiratory rate, what is the respiratory rate where you ever become concerned? When you see somebody's rate at what level, does it make you go, oh boy, I might need to do something for this fella? Anybody else? Will you say that a little? 24. When their respiratory rate is greater than 24, what that tells us is we're not supporting their ventilation. What would you also expect to see with that respiratory rate that's greater than 24? You might see a low tidal volume. You might see an increased CO2. You might see a decreased oxygenation, right? Pieces together, how is it going to impact your patient? So that's in the PSG at night when you're looking at them, but that's also when we're looking at results for them after they've been on therapy. So looking at that low usage, that indicates that our patient might not be tolerating their pressures well. If the doctor said, I'm going to be conservative and put them on CPAP, and we have high pressure needs, they're trying and struggling, they're putting it on every night, but they might not be making it, that might indicate that this is not the right mode of therapy for them. Looking at those comfort features and seeing if those have been adjusted, and again, looking at their leak. We need to make sure that that leak is controlled at 24 liters of less. And last, assessing our AHI. And I think everybody always thinks we go to the AHI first, right? Where do you go first? AHI? When I get phone calls, that's where my people go, hey, their AHI is still elevated. Well, let's look at some other things first, okay? You know, but AHI is important, but we really have to evaluate these other things first, and then we can come back and look at our AHI to make sure that it is in fact controlled. Sustained patient engagement. How are we going to keep them sustained and engaged? Using those regular monitoring tools and escalating those cases that we need to refer to the physicians within the DME. But remember, Mr. Sleep Center, your responsibility doesn't stop the day you do the sleep study and hand them off. In my mind, you still have a continued responsibility of that patient. As pointed out, the American Academy of Sleep Medicine requires that we keep a disposition on these patients, right? So if we're not doing that, we have dropped our area of responsibility to that patient. Managing our resources and our times better by making time to focus on the patient that needs our assistance, not the patient that calls us and wears us out, right? If they're doing well. Educated. Be educated on what to look for, how to use those digital tools, and know who, what, when, and how we're going to use those engagement tools. Having that conversation across the continuum of care, if you're part of an organization, understanding how you want to implement those, and then inviting your patient, making sure in what you're doing. They have a responsibility as well, not just allowing the onus to fall off, but engaging them and giving them their responsibility also. And then when we do that, of course, these are the reports that we want to look at from AirView that we have for accessibility. Looking at that program and process of how we're looking at them, usage, leak, AHI, and then pressure. Making sure we know what mode that they're in and that they are in the right mode. If somebody has treatment emergent central sleep apnea, does that mean they need ASV? What other thing might cause treatment emergent central sleep apnea? Over titrating, hypoxic drive. Tell me about hypoxic drive.
Well, the simplest explanation, I guess, is the one that I've talked before, is just you've oxygenated somebody to the point way beyond where they have been oxygenated, it just tells their chemoreceptor that you've got enough, you quit breathing, and they stop breathing, you start seeing long central apneas or mixed apneas.
But even bigger than that is, again, that's number one, but the number one thing that makes us all drive is CO2. So if I put a respiratory compromised patient on therapy, and they have a CO2 that they live at, and they're like, let's say their CO2 is 65, 68, and I put them on CPAP, does CPAP lower CO2? Yes, it will.
Only if you keep raising the suppressants.
Sure, absolutely. But just putting somebody on CPAP most times will augment their tidal volume slightly and lower their CO2, okay? So if you put them on CPAP and all of a sudden you have this treatment emergent event, that's why I say tidal volumes are fifth sign, end-tidal CO2 is our sixth. If you don't have end-tidal CO2, you always have tidal volume, right? You always have respiratory rate. Two things always on every PSG system you can see. So looking at that patient, if I blow off their CO2 below a level that's acceptable for to them, then now I knock out their hypoxic drive, knock out their drive, I exceed their apnea. So now they start to have central apnea. So develop central apnea. It could be that I overpressurized, but it could also be that I now ventilated them appropriately and lowered their CO2. So if I do that to a patient, is ASV appropriate? An appropriate mode for a patient that has respiratory compromise. COPD, neuromuscular, obesity, hypoventilation. Is ASV the right mode for that patient? What mode would you put them on? Yep, they're COPD. That happened, but you put them on bi-level and the centrals got worse. We blew off their CO2, okay? And you would put them on bi-level. Is that what you said? But what's even better than that? ST with a volume target. VAPS. Volume assured pressure support. Why? These are patients that have ventilation compromise. They need to have a volume target beyond just pressure. Sometimes pressure in and of itself is not enough because their breathing capability, as Dave suggested earlier today based off physiology, is going to change based off what position that they're in, age of sleep that they're in, so that pressure is not going to deliver the same volume consistently. So we would get that waxing and waning, cyclic desaturation, elevation in CO2, right? So just because we have treatment emergent, that's why it's so important for us to know what's happening with our patient, understanding what the history is. We need to understand, is there a comorbidity of a disease state? And if there is, such as any respiratory compromise, ASV is not the mode to go for them. Because ASV does what? Learns their breathing pattern and then ventilates at 90% of it. So if I'm under-breathing already, and I further exacerbate by under-breathing an additional 10%, what did I do to my patient? I created a situation where they're highly intolerant because their CO2 is going to climb even more. And they're going to wake up short of breath because they're going to desaturate and CO2 is going to climb. Does that make sense for everybody? So understanding when we're looking at these reports, what are we seeing? What are we seeing throughout the night with our patient and how are they functioning? So making sure that we know and we're looking at those reports in that 5-step process. That is really looking at putting our patient in the center. And again, looking at your device, their usage, leak, AHI, and then that pressure setting to know what we have controlled. If those central events are there, it doesn't necessarily mean ASV is the mode. We have to understand underlying disease states. We need the whole picture. Patient centricity. Where are they at? Also understanding how to interpret our leak. Now, I've had this phone call happen, and let me ask you guys if you've ever had this happen. You look at it, and the leak 5th percentile says, well, we're like 28. It's not that far off. Not that big of a deal, right? But I look at the maximum leak throughout the night, and I'll see like 140. Anybody ever done that? And then you pull up the report, and it looks like this. So here's my threshold right here. But I see these spikes up and spikes down. Ooh, it's spiking all throughout the night, right above my baseline. That means that the patient's having mask leak, fixing it, mask leak, and fixing it. But 95th percentile, which is, if I plot it on a graph where I'm at 95% of the night, right? That's where we're looking. But I also have to know what is my max. And if I'm still seeing a patient that's having problems and we're not sure about it, do that detailed report and look at your graphic to see, are they spiking up above, spiking up and coming back down? Because remember, it's an auto algorithm. If you're doing this and this, what happens to my baseline? It's all over the place, so I know where I need to go or where I don't, right? Does that make sense to everybody? So really looking at when you're looking at leak and troubleshooting in that manner. And again, just to reiterate, unintentional leak, intentional leak, making sure when you're doing the PSG, as well as when you're setting them on therapy. If they're on a full face mask, choose full face. If they're on a nasal, choose nasal. If they're on pillows, choose pillows. Because that impacts what we expect for leak for that patient, right? And again, as we talked about managing these patients, this is what I mean about a quick, dirty look. I pull up page 1. I know from my most recent days, green is good, red is bad, yellow at the bottom tells me I have a leak, yellow at the bottom tells me I've got an AHI. I know where I need to focus my effort. Does that make sense? Quick, dirty, 2 minutes, first part of your day. Here we are, good, done. Need to follow up with Sally Jane and Bob Bumble. I don't know, I can't think of the last name for Bob right now. Now, at this, I want to talk. See at the bottom here, I have something called Care Check-In. In the Air 11 device, and again, I do work for ResMed. I should have made sure you guys know that, but I figure by now you probably know that already. In our newer devices, we've added a new tool that really engages our patient even further. So we talked about sleepiness, right? In the studies that talk about where sleepiness affects our quality of life. In this study, we're asking the patients at multiple points to engage and answer questions for us in their first 30 days of therapy. Because we know by day 4, if they're adherent and compliant, we're going to have a pretty good compliant patient. By day 30, we're probably going to have a long-term adherent patient on our hands, right? So we're going to ask them questions in 3 different groups, and we're going to cover those 3 groups. But now when you're looking at that patient, you can see how they've answered. So we can see at day 3, 7, how many ever days that's down? 14, 21, 28. Those are the days that they get asked questions. How sleepy were you? How's your therapy going? And what bothers you most? And they're going to be able to answer those questions, and then they're going to get check-in. These are the question groups that they're asked. They're asked and prompted in these series of questions around these 3 things. How are they getting used to the therapy? Is their mask fitting uncomfortable? How comfortable are they with using their machine? How they answer is going to coach them based off where they struggle. And this is called Care Check-In and Personal Therapy Assistant. Now, you've got that call group that calls at 11 o'clock at night. When the patient calls in, they can call. The rest of us don't have that support system. This patient can self-solve at 11 o'clock at night, and if they self-solve, what do you think that's going to happen? Do you think they'll stay on therapy? Do you think they'll be more apt to do it? Absolutely, and it coaches based off their needs. But the other thing it does is by giving you this information when you're following up with them, you can now have a problem-focused conversation. So typically, is your time important to you? Is your time slammed and you don't have a lot of time to add anything extra on your schedule? So I totally understand. So instead of you having a conversation and say, hey, Sally, I see you're not using it. Can you tell me what's the problem? And Sally goes, well, I'm say, hey, Sally, I see you're having trouble using it. Last night you said you were struggling with your mask. Can you help me understand what's going on? Do you see what I'm saying? Or I see that this is still sleepy. Or I see that this says you're having problems with pressure. You are now problem focused. You've reduced your amount of time. You've really driven home what the patient needs for support, right? Patient focused, identifying their problem and treating. When they go to see the physician has the same information. His visit can be more, or her visit can be more problem focused. Does that make sense? So we troubleshoot more effectively. Our conversations with our patients are better, because the hardest part about treating a patient is getting them to tell you the right bloody story and having the words in which to share, right? And then, not only is that, but patient-centric is putting the patient in the middle. Care is individualized for that patient, right? We're not cookie cuttering. So the personal therapy assistant is going to give that patient points where they can, at machine setup, at mask setup, and they have something that's called test drive, so they can acclimate to the mask. Again, they may not be putting it on when they go to watch TV, but when they first go to bed, they've got a few minutes where they can acclimate, and it will give them different pressures and help them feel what that feels like before they lay down to go to bed. Again, once they've answered, all of these videos that they get are voice guided, and it reinforces the education that you have given them. How many times have you educated a patient about a concept and they come back to you, or you call them and say, well, you never told me that. Or the doctor never told me that. but yet we know that conversation was had. That's because they retain less than 10% of what we tell them. So reinforcement is vitally important for that patient's outcome. When we do this, we build confidence for that patient to improve their comfort with therapy. Patient management tools, again, and this is not just, everyone has the app and the online. This first one is ResMed specific around care check-in and patient therapy tailored approach. But having that tool, that engagement tool, using that patient engagement app, as well as using your data that comes from telemonitoring within the cloud. Anybody's hospital looking to improve a telemonitoring sleep program? Anybody? Any physicians doing telemedicine? Anybody want to start one? Anybody want to start a new concept for your hospital? Ding, 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 here's an idea. Okay, these are problem-focused visits. Problem-focused visits pay. You guys understand that, right? Problem-focused visits pay. Get a nurse practitioner, a mid-level, get a clinician monitoring and managing these patients. Ding, 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 we're billing visits. Everybody's about money, right? So again, what are those benefits of care check-in? We're seeing at day 3, 7, 14, and 28 what's happening with our patient, our ability to be more problem-focused, and now we're able to address some of these issues. This is a recent study again that was in the American Journal of Respiratory Care in 2021, and what they looked at is patient-reported outcome with sleepiness. In an analysis of 203,000 patients, large, big data study, they compared the degree of self-reported sleepiness and the changes with therapy when they were adherent with PAP. What they found is that of these patients at day 72, from day 7, 14, 21, 72% of these patients, their sleep, they were very sleepy. By day 28, they had improved their overall sleepiness from very sleepy to slightly sleepy to moderate. These patient-reported outcomes are important on the influence of how they stay on PAP, especially over that 28-day period, and in the immediate term of 6 months of self-reported sleepiness. So when you consider quality of life factors and you consider how insurance pays and when they look at overall patient centricity, those are the things that they look at. How is the patient doing with quality of life? Sleep as one of the primary things that impacts that patient's overall and quality of life. So from that data that we had, we also know that if we have a patient that's still sleepy and struggling to use, remember the conversation may be around transitioning them to another level, moving them from PAP to bi-level, and asking questions like, here are questions that the patient might complain of or statements they may make, and then we need those probing questions and how would we resolve. So looking at those factors are going to give us better insight to engage, and again, consistency is key. Are we asking the questions the same? Is the sleep lab, is the doctor, and that way we're more consistently getting to what our patient needs are. And with that, did anybody learn one nugget at least? Does anybody feel motivated and I want to go out and start a telemedicine program? Woo woo! Anybody have questions for me? I either did a really rotten job or a really awesome job, so not sure which. Thanks, guys. I appreciate you all.